recording, and JJ's going to begin the live streaming, but we want to make sure that everybody is aware of that and that we're muting unless we're talking, just so we get good audio. Thanks, everybody.
All right. Well, happy Friday again, everyone. It's great to see you. So I guess what we'll do first is we'll just kind of recap a little bit what we went over last week. Was it last week or was it 2 weeks? The last time we met. So 2 weeks ago. So we'll just kind of recap on that and then quickly review some of the things that Izzy sent out earlier this week, and then we'll break out into our work groups again and kind of start fleshing things out just a little bit more. So last week, or 2 weeks ago, we went over actually, let me pull it up, or if somebody else has it up and wants to share their screen. So we went over the form for completing our goals, objectives, and strategies. And on that form, there were some, so our goal is already determined. Sorry, I have a hard time doing two things at once here, pulling this up.
I can find it and pull up the template for you, Tiffany.
Amazing, thank you. So our goal is that overarching, preparing Marylanders to afford the 100-year lifespan. Then when we broke out into each of our four subcommittee work groups, we talked a lot about the objectives and how they are to be high level, using that SMARTY format where there we go, perfect. So they're to be high level, using that SMARTY format, specific, measurable, achievable, relevant, time-based, and inclusive and equitable. Oh, perfect, thank you. So we took, there was somebody in each of the sub-work groups furiously taking notes, and Izzy was kind enough to kind of summarize some of those notes. And she and I talked through them and pulled out some key themes, what we think are key themes and priorities, using the conversation notes that from 2 weeks ago. And so with those, we wanted to put a few of those into the recommended format for objectives and throw them out there for people to give you guys something when we meet today to sort of talk about or to work through. And when we break out into our subgroups, remember that the work groups, objectives that we sent out are suggestions. It's kind of like what Izzy and I thought might be everybody's priorities just by reading through the notes. But there are blanks in the objectives. There are, room to add, whether it's a timeline or a completely different objective. This is really for you guys to talk about and sort of flesh out. And then once we get those high level objectives tackled in our work groups today, then we're going to start working on the strategies. And so I think a lot of what came up the last time we met were strategies, right? So the strategies are how we're going to make this stuff happen. Those are the more detailed, the more specific, whether short-term, midterm, or long-term. And that's the part I think that everybody is really going to be excited about. And that's really where, folks can add their area of expertise, like, oh, I prioritize this population or this, and I have expertise in this area. And that's really where the strategies come in. So I can pull up, I do have, I guess, are there any questions about the format of the goals, objectives, and strategies, the form or anything like that before we go into a quick review of the notes and sample objectives? All right, I don't hear any. So then I will share my screen here and show you the start with. Okay, so the first one up is affordable healthcare. Can everybody see my screen? Is that good? Need me to zoom in a little bit? Perfect. So this was just a quick summary, some of the high level ideas that came out of them, came out of the conversations. So I won't read them all to you, but I'll pull out a couple. So the affordable healthcare overall with a focus on mental health and substance use. Improvements to Medicare because it's not adequately, it's not adequate for older adults. No dental care under Medicare. A focus on malnourished adults, peer-to-peer support, and the use of technology. And some of the recommendations that the group had brought up were parity in Medicare, reduced facility care cost, and reducing the reliance on hospitalization. Provision of dental care, strategies for making transportation accessible and affordable so that people could actually get to their medical appointments, and creating avenues where peer-to-peer support groups will thrive, kind of like the village concept. And so after reading through all of those, Izzy and I thought that what we were hearing were that the common themes were really reducing costs overall, expanding access, and focusing on a holistic approach, whether that be through dental care, substance use, mental health, expanding access to multiple people and focusing on preventive care as well. And so just tried to throw together some high level proposed objectives to think about and to noodle over. So again, we've got the time sensitive format. We've got by 20 whatever, reduce healthcare spending by X% and utilize the savings to expand Medicaid access to X number of older adults. Second proposed objective to consider, decrease unnecessary hospitalizations by X% over the next X years. And increasing coordination of clinical community connections that address social determinants of health and providing upstream intervention to improve health over the lifespan. For this one, we would need to figure out also a timeline. I didn't put it in the formula, but also need to just figure out a timeline and those key metrics on how do we measure success? Because that's a big part of this, right? So it's got to be, how do we measure success and by what time frame do we have to be successful? Any questions or thoughts about that first overview before I go into the next one?
I have a quick comment. If there are slight kind of, I guess, slight kind of things that may not be exactly, I think on point. I mean, I think you've done a great job capturing, the kind of the conversation that you weren't even in, so I think that was a really great job. If there are kind of slight things that may need edits in these notes, there's room for that in the work group process, right? In the committee process, subcommittee process, right? You're on mute.
We're going to break out into our work groups, and you guys are welcome to further refine these, completely wipe out the proposed objectives. This was really to just kind of help, sometimes these high level concepts are sort of nebulous and you're like trying to do so many things.
It's really helpful. It's really helpful. It's helpful to have something to start with, to kind of react to and respond to. So thank you.
Dan, that is exactly what we're hoping to do, is give you all a starting point at the subcommittee level. But the idea being, today is the day we want to try and build consensus around what is the one thing. Is there one thing that we can agree upon as being the objective?
And in terms of, I'm sorry, Izzy, but real quickly, in terms of like the measures being used, I mean, I understand, so I think that might require some research. You know, I don't know that our group may not just have off the top of our head what are the best measures for this. I mean, I really like the kind of, you know, the addressing social determinants of health, getting upstream, doing the clinical community connections. But, you know, there may be measures being used elsewhere, you know, across the country or something like that to kind of to get to this that we're just not aware of, you know, that it may be worth kind of taking some time to, you know, instead of just kind of trying to come up with measures off the top of our head in the next 90 minutes, maybe kind of take some time to look and see if that's happening elsewhere that we can kind of emulate.
Yeah, absolutely. And I think that, so let's say that your work group gets together and you're like, I really love this objective, and we have a little bit more research to do. But you know, like to pick out what the timeline may be or what those key performance indicators may be. I feel like there is some flexibility in that. While the goal is today that we will have come to a consensus, if there are little details like that, little details, right, to work out, you know, I think that there's still some flexibility, because the ultimate goal is we have to have this whole worksheet completed for the state by November 15th. Is that right?
Yeah, you know, we're trying to get things wrapped up in time to you know, find out if there's, you know, redundancies in what we're, you know, recommending, if there are gaps and things like that. But Dan, I wouldn't get caught in the weeds about, you know, research elements and things like that. We'll have time to, you know, help identify.
I don't want to get caught in the weeds. I don't want to do that. No, I'm glad.
Okay.
I didn't want to do that. So good. Thanks, Izzy.
Yeah,
Thanks.
the most important thing I think is because you guys are the experts and the stakeholders, to really get what your thoughts are, what's important to you, and making sure that these objectives that we're going to be presenting and putting in this plan are what's important to you, to your organizations, and to those that you serve. Would you like me to, are there any other questions, or you want me to go over maybe quickly some of the other ones? Oh, Fran looks like she has a question.
I'm just wondering whether the time you're taking right now to kind of go over everything might be better spent by us kind of going into our group and kind of really working with the great work that you guys have done already for us.
Great. If you guys are ready, I am more than happy to not go over this stuff, because right, I mean, you guys have the paperwork. You get into your groups and really start fleshing these things out, because it is I'm sure that there's a lot of conversation to be had. So
JJ has already set up the breakouts, and you all have been assigned to those. We also have excellent MDOA staff also will be present too, to help take notes and help you know, clarify if there are questions during the discussion. Okay. So JJ, can you help us get people to those rooms? Tiffany, are you okay with that? Okay.
conversations, or do you want me to kind of give a high level overview or thoughts or anything?
I think you all did a really good job of summarizing the major points that were discussed and then thinking about them in terms of themes and so on. I spent a lot of time studying this and have some suggestions and comments and reactions. And I would assume other people did too.
Great. Well, Fran, do you want to kick us off?
I would be happy to do so. Let me just focus on themes right now. As I looked over everything and I sort of thought about themes, I realized that the first one really is develop housing, preserve existing housing, and create stability. So we're really talking about develop, preserve, and stabilize. 3 different components right there. Under options, I think we want to talk about not just housing types, like, condos or apartments and things like that, but I'm wondering if we also, when we talk about affordability, we're also talking about whether we're talking about ownership, rent stabilization, things of that sort. So there's really 2 components to it, financial and housing types under options. And then the third one, safety and livability are important, but to me, they're all about structural. We also talked about things like that relates to what I would call quality of life. It's things having to do with the need to be independent, aging in place, community, social isolation, issues like that. So I would add quality of life to that theme. And then the last one, I don't know if it was stated clearly, but it might have been hinted at, which has to do with partnerships. I know that this is a state plan, but housing's not going to get developed by the state. It's got to be done with partnerships at the state and the county level, with the private sector, with developers and so on like that. So we might want to put in either collaborations or partnership is another important theme. Make sense? And how would the rest of my subcommittee members think about this? Does this make sense or what?
And if anybody wants me to reshare the screen, I'm happy to do so. Just let me know. But this way we can that way we can see everybody's screens and chat a little bit easier.
I think if people agree with Fran's suggestion about clarifying the themes to include a little more detail, in addition to her thoughts on options, that they are financial and housing type options, I think they're also personal choice options, like personal preference options. I don't know how to wordsmith that, but that kind of covers what you were describing under safety and livability about community and things like that. That's to me, that falls under options. That that option to age in place could be age in the same physical place or age in community in a different place. But yeah, I think all of those things are valuable to capture either under themes or in more detail further on, whichever makes most sense to people.
And so the themes section was really, that's not part of the worksheet that actually gets completed by the state. That was just to kind of say like, okay, these are the common themes to give us like focus areas to discuss. What's on that, the worksheet that we are going to be completing for as part of the plan are those objectives to consider. And so what we're hoping about today, or what we're hoping to come out of today, is how do we get those themes? And it's good that you did kind of expand on them a little bit, but how do we make sure that those are illustrated in our objective? And technically, we presented the 3 objectives for each work subgroup to talk about, but the goal is to really arrive at one, because ultimately our whole affording longevity comes up with four objectives, and those 4 objectives will likely come from each of the 4 like one from each subgroup. That makes sense.
It makes sense. It just sounds impossible.
And so that's why we tried to do, that's why we tried to do some work behind the scenes to sort of like, because there are so many, like there's so much that needs to happen, right? And that's also why we were trying to keep those objectives as general as possible, because then in our strategies, because we get 8 strategies per objective, right? That's where we're going to get more bang for our buck. And, you know, like Fran was mentioning, all of the collaborations and all that, that can be the how part of how we meet this objective. But the goal is to keep that objective really broad so we can fit more things in,
Yeah.
if that makes sense.
That's the challenge, is identifying and getting behind a one objective that's comprehensive enough that allows us to fit a whole bunch of different kinds of strategies underneath it that support that objective.
So in a sense, you've articulated 3 objectives, and then it's like, it's as we refine those objectives, it's then rewording them into one global statement objective. Is that really what you're talking about? I mean, that's fine.
Whatever we want. The 3 objectives that we provided were just kind of food for thought. We don't have to use them. We could use parts of them. We could combine all 3 of them together to make one. But it really is like, that's what our conversations are about today, is what do we want to put forward, to put forth in this plan.
Yeah, and I thought that I thought all 3 of them were fine, but needed to be tweaked. And so I'm going to go ahead and tell you how I spent a lot of time on this all day yesterday. I was pondering all of this too. So I thought that the very first one, what was missing from there was the word accessible. We talk about affordable, but we don't talk about accessible. And I think that that's an important word when we talk about housing for people for older adults, is the issue around accessibility. With the second one, I kind of didn't understand how we got into, I think it was originally phrased as, was this the one about evictions? Yeah, evictions. And I was thinking, well, you know, that's not how people lose their housing. It's one way that people lose their housing. But I really think that maybe the language ought to be looking at decreasing the major obstacles that contribute to housing instability for older adults. Because when you think about that, you're also thinking about not just rent or finances. You're thinking about things like, you know, access to transportation, the fact that the house itself is not accessible. There's too many steps for people to climb, and they no longer can climb, you know, steps, things of that nature. So I thought about focusing on the larger issue, which is decreasing major obstacles to housing instability. And then the third one, this is where I added quality of life. Preserve existing affordable housing for older adults that meets their needs for safety, livability, and quality of life. And that's where that's where I would put in things like choice. I would put things in like where you're living, the issue around social isolation, the importance of access to services. That's where the village program component could play a very, very important role. So that's kind of where I ended, and I can see all 3 of these sort of being a part of some broader language around housing, affordability, and accessibility, and quality of life, something like that.
The beauty of this plan too, because there are so many of these like sub work groups, some of those things that you're mentioning are also going to be mentioned in, probably going to be mentioned in the objectives and goals and strategies in other work groups too. Maybe, you know, some of the things
Sure.
will be connected to ours, like the LTSS, or maybe it's in some of the other actual under the 4 EPIC goals. So, right, we can put in as much detail, and then if they're once the state is going through everything, if they notice that there's redundancy or able to like kind of, you know, mesh things together, then that will happen, I guess, behind the scenes before it all rolls out.
So really, it's up to this group to just make certain that the issues that we think are paramount when you talk about housing and older adults, that those concepts are there, so that then they can be looked at in a whole with the other subcommittee recommendations.
Yeah, I think that I think that that's right. But we, you know, like we have our notes in our priority areas, and some of those little like specific things that we've mentioned in those notes can be sort of funneled into our strategies, right? So that's how we meet that. So if we,
Sure.
I liked your wording around the decreasing the major obstacles, and you know, maybe that is around creating villages. Our strategies are around creating villages and, you know, eviction and reverse mortgage counseling, you know, like things like that.
Yeah.
So, oops, and somebody, we've got some notes in the chat here. Let's see. Oh, great. So Chelsea has to leave a little bit early. Ruth said, how about replacing evictions with involuntary displacement for financial considerations? Yeah, I think that's good too. And remind me, Izzy, I can't remember, do the chats, these sub work group conversations are not being recorded or transcribed? We're just
They are
taking notes?
not, we're taking notes though. That's why staff's here. We're going to try and capture as much as possible.
Okay,
Okay.
I'll make sure that I pull anything that goes into the chat. So if somebody has an idea and they plug it into the chat, I'll make sure that I copy and paste that in my notebook so that nothing gets lost. Other thoughts or?
Yeah, so I have a lag on my screen, so just if someone can maybe like wave like crazy if I can't be heard, because I don't know, that seems like I'm having internet trouble, but I can hear everyone just fine. So on the I like, Fran, I love what you said. You said a lot of content that was very helpful. So you know, one thing in general that about the affordable housing objective that's put on here, we as a state don't have a way to increase affordable housing. Like, that is determined by the federal government. They give us a LIHTC allocation each year. We roll it out and it builds 4,000 units a year. And you can either preserve, you know, 4,000 units, or you can build 4,000 new ones. It doesn't matter. The answer is 4,000. And whether the federal government increases the allocation or not is beyond us, and it's beyond our control. And that's all there is to it. So I don't think it makes sense to have that as an objective, because it's not something we can control. And just, you know, federal dollars for affordable housing, that LIHTC is the way that affordable housing gets built. Now, the state does have a gap financing kind of mechanism that we do use.
And we not only mean that people could actually like know who to call and be eligible to get those services, but that they could actually access them physically. Because that's
that's why it's home. Yeah, that's why it's home based. You know, that's why home base is a big piece of that. You know.
Okay. I'm kind of trying to get at the point that we have a lack of physical accessibility within our behavioral health system that is very concerning for inpatient and community-based services.
So expanding use of technology too, expanding use of home-based services. Those are the things that are going to address, I think, that is kind of accessibility issues, Stephanie. At least, you know, there's some things that will help.
Yeah, I think that'll be one thing. And I think it has to be a requirement that services have to be ADA compliant. I mean, for some reason, we just don't have that requirement. I don't know why. I don't even know how it's possible, but we don't require it.
And to be honest, reducing the cost of healthcare above, I mean, to be honest, all this stuff is strategies under this top stuff too. Building this network of care, making care more accessible. Again, more affordable, more appropriate, affordable care, more accessible is a strategy under number one too. I mean, I don't know if we need to break them out in different places, but
Liz, you're so good. You're just capturing it all. We'll figure out where we put it later.
yeah, no, I like it.
Yeah, I'll just put them in both sections. That makes sense. And I think what's nice about the language that was put in here is that, we were talking, is this the cost to the individual or the cost to the state? But this framing is the cost to the state improves the ability to then do the strategies that you guys are talking about to move that money over. And I'm not sure that we have a concrete, I don't think we have a process for that at the state right now to say, look at these savings, how are we reinvesting them? At least
Jonathan,
not a
I don't know
totally
if you can
transparent
hear me,
process,
but
which
I'm joining the meeting late.
to
Is there
just
a
to
way
track
you can
that,
put
right,
me
and to get a better
into
understanding. To me,
a,
that's a strategy potentially.
Mhm.
a work group for financial
So-
security, possibly?
Um, So again, right now we're getting into the strategies here, and we're supposed to be kind of talking about trying to nail down 4 objectives. But again, I think the first objective, I think the first and second objective look good. I don't know that we can come up with numbers like this yet. I mean, I don't know. They said they told us not to get into the weeds, and I don't. I think we would be hard pressed to just and silly for us, just us 3 to just come up with random numbers off the top of our head for this is how many hospitals until we look at the data, until we see the data for how many hospitalizations are there, how many could we reduce by increasing this access. See, I think there's a lot. I think there's a little more that we reach, like a little more things that we have to look at before we can just pull up numbers out and say reduce by this much over this many years. I think it's a good objective, but I think the numbers take a little more work to come to, and if we want to come to, if we want to
We don't know
come,
what our baseline is,
if we want to come to well-reasoned numbers, I think it's going to take it. So something that we can defend. I think we need to do a little bit more work.
Yeah, we need to know where we are so we know what we want.
Right.
We don't even know the baseline. So
Right.
yeah. Do you think it's worth having a strategy? Are we even supposed to be doing strategies, or did we just naturally go to strategies and you're capturing them, Liz? Like,
I think the latter.
I think so, but I wouldn't let. I think understanding the strategies can also help inform how you're going to frame your objective. It sounded to me like the goal was to get to the objectives.
Yeah.
But your route there might be thinking about the strategies, sort of how you're talking about, Dan. Well, these are strategies that have to do with both of these. I wouldn't get stuck in like where should we place things,
okay,
but rather what are
Okay.
the things that we want to do and what does that mean for what the objective should be?
because
So
I
I think
want to throw something out there that's been like on my mind for years now. There does not exist in the state of Maryland a behavioral health long-term care option anywhere, but where I would want it would be in the community. So it just plain doesn't exist. Like there isn't anything on the Medicaid home and community-based side that's specialized for people with a behavioral health condition. And on the behavioral health side, there's not actually any service in the public behavioral health system that's intended to be a long-term care service, like something people get long-term. So it's where this whole 1915I thing came from that like doesn't quite have legs yet. But I feel like that's a missing link for us.
Sorry, is there a 1915I, or you're saying
There is
There's
a
an opportunity for that
1915I
group.
for kids. There's some technical assistance we received. We, few of us, some of us came to the consensus that we need a 1915I for adults that would pay for an array of services that are intended to be long-term care. And just so you know, Liz, like the public behavioral health system consists of like outpatient clinical services and then rehab services. So they're not, like by definition, they are not intended to be long-term services. And so there's just people who require long-term support who are just falling in the cracks of those two service arrays right now. And so a 1959 could be long-term. But we don't have to be so specific as a 1959. I just think the glaring gap is that there is no home and community-based, long-term service or support designed for someone with
And I think
behavioral-
these are getting into the strategies a little bit. I mean, the same thing we can say improve the pass our screening process, you know, which
Oh, yeah, throw that in there.
that would decrease unnecessary hospitalizations and
Yep.
hospitalizations too. But again, that's something we'll probably get to that next meeting. I think we should probably, you know, but it's worth putting it in there. It's in there. So, but I think improve pass our screening process is a better word. Yeah, improve. But well, how about so for the third one? Do we want to come up with 4 objectives? That's the goal. So I like what they came up with here.
I just don't know what it means exactly.
Who said that?
Stephanie.
Yeah. Well, I think it means, you know, when we talk, I mean, for instance, you know, Robin was talking, you know, I mean, housing is health, you know, and so it's a social determinant that, you know, how, if someone has housing, they're likely to be more healthier. And so I think it's that coordination of, you know, the clinician side, you know, the provider side, and making sure that they're working with, you know, the person to kind of get their other needs met, you know, so there's not just a clinical thing, but that they're working to meet the individual's needs, regardless of what they are, whether it's food, whether it's housing, whether it's employment or things like that. So all these things, I think there should be, I think what this is trying to get at, and what I understand it to mean, is that there should be increased coordination, which is basically what it says here, between the providers, the people delivering the healthcare, and the people, the things that keep people healthy in the other social determinants of health, you know. And so there should be more of a coordination of effort across those paces, is what I think it says.
Yeah, I agree on that point, because right before this call, I got a call from Johns Hopkins Healthcare for somebody calling us because we went out to look at the person's roof, and her roof is leaking and causing mold. So it sort of works hand in hand. Yeah.
I guess I totally see that. I'm not sure we've written this objective in a way that we would ever be able to know if we met it.
Yeah.
Also,
I guess-
upstream interventions. I heard you say that earlier, Liz. I feel like sometimes we do just start kind of agree on some jargon we're going to use that I don't like. Do we have a definition of that? Like, what exactly does that mean?
That's a good point.
I think that's just a general public health framework for thinking about prevention earlier in life rather than a treatment model, right? So the types of things that you guys are talking about. But do we have a specific, I totally agree, moving it away from sort of the talking point to the objective. What does it mean in a way that anyone can understand what we're saying we want to do, and what's the measurement around that?
Because I would think you would see fewer older adults experiencing homelessness. Like these are the things that you would measure this by, right? Or am I being too concrete?
I think you're right.
Which we've seen an increase in older adults experiencing homelessness, and many of which for the first time. So we would want to see you doing things that are sending that in the other direction. And I'm trying to think what the other
was older and semi-retired. You know what I mean?
Mhm.
But they're not looking on Indeed, I don't think. But if
Well,
there
but that directory is an interesting idea, that it
Yeah.
could be a Maryland state directory for employment opportunities and matching.
yes, and matching with employers with their capabilities. Okay,
And- And have we talked about terminology? Are we doing 50 plus or seniors or older adults? Where are we in the semantics of longevity, Ready Maryland? What are we using? What are we calling ourselves for older adults? Has that been discussed, do you think?
No, but I read online where there's a big discussion about it. You know, what people think is a senior or elderly or whatever. But I think that's changing, right? 60 is still young to me, viable. So
Then
maybe we're talking, what are we talking about? helping them with these programs? So that would that be 65 and over, the special programs, or would it be 60 and over?
Yeah, I don't know. I don't know the answer to
62
that.
is retirement,
Are we
right?
just-
You can get your Medicare at 62 is the earliest. So being able to
Medicare 65.
okay.
Yeah. So, but you know, the ageism could be people 50 and over. You know, I think that in the workplace, people 50 and over are definitely subject to ageism in the workplace. So but I don't know where the committees are looking at that cutoff, and then how are we discussing it as semantically? Are we calling, you know, elders, seniors, older adults, 50 plus, 65 plus? Where are we at? I don't know if we need to do that in this work group, but it's just something that I would think all the work groups need to be in concert with.
That's very, very interesting. But I would never call a 50-year-old needing help. Nowadays, they're very valuable and should be out there gainfully employed.
Should be.
Should be. So I don't think we should subsidize people who are lazy and want to retire at 50. That's their problem.
Lazy. Okay.
I think they should change the age to 70 for working. But anyhow, my thought. Hey, that's one thing. We could say that, right? How do you afford it? So you change the retirement age to 70.
I think it would be, I personally think it would be good to be generic with age overall, unless we're talking about a certain program. To what Carl was talking about earlier was a webinar yesterday for National Ageism Day, and there's this really national push to take away the stigma of aging, and so the less labels on age, I think the better that we have. And I think our overall theme so far from last time and what we've talked about a lot this time is really all ages, to prepare for longevity, not it down to something in particular. But I know that makes it difficult in another way too. So.
Right. And maybe it's not for us to determine, but to give suggestions, right?
Yeah, so I would just say it's great, fruitful discussion that you all are having, but I don't think you need to worry about the specifics of that definition, especially considering that, as you brought up, you know, we have a larger work group and an even larger, you know, program happening, and we just want to make sure that everyone is all in the same accord. So we'll definitely figure that out on a much larger scale and hopefully provide more guidance if needed. But I don't think we need to get that specific for this meeting.
Have we gone over our 3 things? Oh, how to increase the average salary of workers between the ages of X and X. Well, by reducing their taxes they had to pay. I think Carl said that if you're in this protected class, then you can make more than Social Security says you can make, right? Before they decrease your Social Security. So removing barriers would be one way to increase your salary, right? Lessening your burden and wherever you can. Again, not for us to figure out, but for them, a suggestion.
Right.
I don't think you can ask an employer to pay more because they're a certain age. That certainly wouldn't be an incentive to hire people.
Yeah, that's good. That's very true.
So my only thing is, if somebody can come up with something, is reducing the tax burden.
Well, or could you just come out with policy statements to employers that make sure that they're not discriminating against people in any age class. So if you have younger workers between 30 and 40 who are starting, you know, their career building, wealth building of themselves and their families, and they're, you know, they feel the need to have certain percentage increases in order to stay in that particular job, are employers going to discriminate against the older workers that, are at a different place in life by not giving them the opportunities and increases in their job responsibilities that they would to the younger workers. So how do you create equal opportunity in the workforce for people of all age spans?
Mm-hmm.
And I agree with that, David, that maybe there has to be another educational piece that we inform the employers that discriminating against the aging is against the law. Because we see that a lot of times that older people are working longer and want to work longer and have the ability to work longer, but for some reason or another, they don't get those opportunities to do that. Whether it may be from the employers wanting to move their corporation to a younger workforce, or they just can get a smaller salary.
Right. Well, there is already a law that protects if you're 40 or over from discriminating. That's on the books for many years. But I think, from what you're saying, is do the opposite. Give incentives to employers to keep those people, not let them go keep them.
Or just an educational piece to let them know that they shouldn't engage in that practice. They should let people go on and work to their ability as long as they're capable and do the work, for just giving the employers, we're watching you. We're watching you. You can't do this. You can't just lay off somebody because they're older or something, like a lot of times you hear about that happens to people. So I'm just making it an educational type thing. Maybe we can put out there also.
Mm-hmm. So those, I think, are the areas that we have to talk about, right? We have the 3: increasing retirement savings, educating the population, and how to increase the salary of the workers.
Mm-hmm.
It is, and I, again, sorry that I'm coming in late to the conversation, but is our job at this meeting to fill the X's in with actual numbers?
No. So
Okay.
thanks for jumping in to kind of reorient us, because I think we have a little bit of time left to really understand what's going to be reported back out to the main group. JJ just jumped in and he actually provided the document, which just contained the sample objectives and strategies. David, prior to you joining us, Tiffany and Izzy opened us up and provided an introduction on what the instructions were. And so the group has been tasked with looking at some of these objectives. There are about 3 of them that this discussion has gone through. Thank you, Mary Lou, for reading them through, and Annie and Carl and David, of course, for contributing. So I'm just going to reread one of the potential objectives again, and the assignment is going to be to select an objective that is going to be reported back out to the main group. This work group is going to be responsible for reporting 4 different objectives for preparing Marylanders for affording longevity. And so this particular subcommittee is, financial security, and we'll be reporting out one of those 4 objectives that we find, the most, I think, cohesive and has the best identified strategies that we've talked through today. So just as an example, one of the objectives, sample objectives was by 2030, increase the proportion of adults who report participating in physical activity or exercise by 5%. This is just a sample. And then the potential strategy identified for that was by 2027, community-based organizations will work with older Marylanders to develop physical activity programming policy and promotion that incorporates pedestrian transit routes outlined in Maryland's Complete Streets Initiative. I'm just going to copy and paste that and put it in the chat so you can kind of see. But now I think it's good to orient you all to selecting one of the objectives, since we've yielded some conversation around them, and kind of come together and try and identify which objective you believe works best and which identified strategies you would like to see the Maryland Department of Aging kind of push out and push forth as part of this work group. Does that make sense? Are there any further questions about it? I'm just copying and pasting a sample.
So you're saying that out of all of our discussions, we're only supposed to come up with one objective?
That's my understanding, because from this recommendations, and JJ, you can jump in here, but from the recommendations, it only looks like the work group itself is going to come out with 4 recommended objectives. So, and I think, and I believe
the vision of it, but within the work groups, I would hope that they would be able to come up with more than one objective. You couldn't tie it all into one. I don't know. Can you get clarification on that? How many objectives are really supposed to?
If there's 4 work groups, then they're probably saying 1 per work group, and then that's 4.
Yes. So, so there were. I'm trying to find where I had my notes. So, there were 3 objectives to consider that came out of this conversation. That it's on the objectives to consider. Put on the
sheet. Right.
Yeah. So selecting one of those and then trying to tie in. And honestly, with all the discussion that was had, there's so many different strategies. I think even if it was discussed in topic number 3, it could still be applied to topic number 2 or topic number 1. But the idea is just to come out with one objective out of those 3 proposed ones, and figure out which strategies you feel like can fall under that bucket. So I think it was good conversation. I mean, I think it's good to just walk through all of that and retouch on notes. But that'll be your assignment or task, is just to figure out which objective you think.
We could just make a run-on sentence and include them all into one sentence.
Yes. Comma and semicolon.
Hey, Jonathan or JJ, you there? Nope, never mind.
So it's 60 minutes for the subcommittee, 15 minutes for subcommittee to report back to the work group, and 5 minutes for the end. So I guess we're supposed to go back 20 minutes.
Okay, so about 10 after. Well, so why don't, if y'all want I might just suggest it's, instead of saying expanded access, because access becomes the noun of that sentence, expanding enrollees into LTSS or recipients, isn't that probably more of the word you're looking for? Because access isn't the problem, it's getting people into it. Okay, so I would just kind of add that, expanding, recipients, enrollees into LTS. And I think what this group would just report is to say, to get the measurable goal, some more, somebody's going to need to take on kind of where are we currently at, and then what looks realistic. And I think that's fine. I mean, this group could reconvene, in 2 weeks just for, an hour to talk about that. I would then just say, maybe we want to take the time to talk about, okay, what are we going to do to expand enrollees? Because then that comes your 8 steps of here's physically what we think the state needs to do to help more people get services. Okay. It's ultimately getting people into services. With your ultimate outcome would be to reduce wait lists. It kind of works real well. But what are some of the specific things that could be done? And I think maybe one of them needs to be, reassessing the income thresholds. I'm throwing it to you guys, but I think that needs to be looked at in expanded income thresholds, but that would be a strategy.
Yes.
Carrie, I have a question. At what point in the process is somebody considered to be enrolled? Is that when the adult evaluation and review is completed, but before they're actually gonna get services, are they considered enrolled then? Or?
On MDH's LTSS website, they are considered pending until their services are initiated. So, for instance, someone could have a plan of service, an initial one that's been submitted and waiting for approval, and I've seen them hang as long as 14 months. So they're still pending until those services are initiated.
Is there any access that we could get to find out, like all the counties, how many are pending? Like just right now? Is that?
I have no idea how we would get that information.
I mean,
I just want I don't
could
know
ask Amanda. It's a lot. I can tell you it's a huge amount.
Well, it would be nice to have that number.
Yeah, we've got, legal aid is working on some stuff right now just because of all these CFC disenrollees and people that are on SSI have been automatically put on Quimby, and you can't have more than one Medicaid code in LTSS. So people who had CFC are now being dropped off, and it's a nightmare getting them back going, but that's a whole other committee.
Yeah. Wow. Yeah, I just wondered if using the word enrollees was really going to capture what we meant.
It might be recipient, and we could expand the sentence.
I think that's a better word. Yes.
Yeah, expand recipient receiving services.
Yeah.
Through LTSS by X amount. That way you've talked about they're actually receiving services.
Yeah, that's good.
Yeah.
Yes,
By
perfect.
increasing utilization. Yeah, there you go. So at least now you've got actual somebody getting services, right?
Right.
So then you can stop that semantics that you talked about, Carrie, of registry versus whatever. So it just kind of helps define the goal a little bit, or the objective a little bit more. So I think thresholds is one of your strategies. I would ask y'all what are maybe some other strategies to actually get people on services quicker.
Funding.
Funding and outreach that we talked about, I think.
Caregivers.
So increase funding through certain services. Is it the funding that's keeping them from getting into the program?
Available caregivers, available services, available employees, and funding. All of it.
And that stops them from getting in to it?
Oh, it might not. No, once they're in it, just receiving it.
Yeah.
Receiving the resources. It's limited by income. I mean,
right.
by
Remember
funding.
this is right, but this objective is about them starting services.
Okay. Yeah. Getting ahead of myself.
Yeah, I'm not saying that that's not going to come. All this is going to come back to funding, but you can't just say we need money and then say, okay, state. But for them to get in there, I wonder, I don't know if y'all saw this, but, nationally, there's actually some lawsuits going on with certain, it's getting enough people working in the departments to get the people through, because there's just not, Carrie, like you said, you receive X number of calls a day. Okay, if I receive 40 calls a day and I can only process 20, inevitably you're never going to get all 40 through, because you just can't do what physically can't be done. I deal with this in another group, which is, we need to have more surveys done. Well, you don't have enough surveyors. And so there was a real hard push that was put on the state of Maryland to get those surveyors in place and threaten with the lawsuit. We're not going to threaten with the lawsuit, but a lot of others are doing that. So to actually really push the state of Maryland to fill open positions and or create more positions to process people.
Yes, big time.
So that might be a strategy.
Yes,
Because
increase in
previously we had
state.
talked also about the family caregiver situation. When you have a readily available person that lives there who can quit their job if they're going to get paid to be the caregiver, that takes care of that issue. But being able to have that administrative staff to be able to process the paperwork, process the plans of service, I agree. I think that that needs to be a push for for
That's
everything
all
you
the
said.
services. That's all the services, including, you know, SNAP benefits. I mean, all the benefits. It's just getting it processed.
Which I think is a real big problem. I mean, getting people
Mhm.
onto Medicaid, just straight Medicaid, there's just not enough people at Department of Health to process the numbers that are sitting there. You can't, because there's so much to be done. And there was some talk about, you know, shortening the look back time, allowing houses not to count as assets. So those are strategies to help get people off of wait lists, but you still got to have the people
Yes.
process all of that kind of stuff.
And you also have
So-
the people to help with seniors processes, because a lot
Yes.
of seniors are not technical. They don't even know how, or they're informed that they have to do it online, or they have to go into a local office, which a lot of times they can't do either. So if they don't have a family member to help them, you know, do the applications for all of the resources, then they just don't get them. They just say, well, I don't know how to do it. I can't, I don't have anybody to help me, that kind of
Yeah.
thing.
Yeah. So the word navigators come up a lot in some of the other work groups to create a navigator, kind of a state navigator process, which we kind of have. That is what LTSS is. But again, you got to get the person there, but to help. So I might be just
we need more
talking
of
what
them.
I just said. Right.
need
Well,
more of
so I think that needs to be a strategy. We need more people to help process, physically process.
Yes.
Like I will say with calls that we get, you know, I had someone who said, oh, my family won't help with this. And so I said, can I have your permission to call the daughter? And I called the daughter and said, look, you won't have to worry about her if you can just help her get this application done. And that helped, you know, it worked. But it's having a person to be able to go through and make those calls and do those things to connect those dots. So I agree. A navigator is an excellent way of doing that.
Yes.
Is the application process overcomplicated?
It's long, and it's a lot of supporting documents that you have to get, and that's just for CO.
Well, one of the strategies may be to reevaluate the assessment process or application process to with the goal to reduce the burdensome paperwork or something like that. Because I think like anything, like any good state, and all 50 of them did it, that we overcomplicate things by making too many documents needed.
And the biggest holdup appears to be eligibility and plans of service. So that makes sense.
Yeah. So I think that might be a strategy to assess and reduce the application process. I think it would also be nice if there was you could put this in the same strategy, but a cross-sector application. You know, Department of Health has an application through MDOA. Getting into senior care, we have an application within that. They still have different applications. Anne Arundel County has one system, Ames, and you go to Garrett and they have a different system. Amongst our own department, we have different application processes, which we need to do. So I think all of that can go into that kind of strategy, that the application process itself is burdensome and probably very outdated and not necessary.
That's a great point for access.
There should be more navigators locally too, like in senior centers.
I think that's a great thing that you could add into the navigator one, more local, regional navigators versus statewide. I think I agree. Those are both strategies to help. You're right. Yeah.
There's a lot of that kind of outreach for SNAP. So maybe that's kind of a model.
I think one of the strategies, and I think you were saying it, one of the strategies also could be overall awareness of services. I think every group is going to come up with that. But you were talking, Ian, about that a little earlier, that they just don't know what all's out there. I think everybody needs to have a strategy. We got to continue to better access some sort of statewide resource or more regional resources. So I think a part of a strategy of more collaborative resource available through LTSS that people could access would help them to know if they even got a call.
Mhm.
So, all right, we got 7 seconds. So, all right. I hope that was enough. I didn't mean to take over.
Liz, real quick, just to continue our thing at the end, I would be happy to schedule something if you wanted to talk on the phone like Monday or something, maybe, because I think it's really important that you understand that. So, I would love to kind of talk through that with you a little bit more.
That sounds great. I'll follow up with you.
All right.
All right. Hey, everybody. It's funny. It shuts everybody's cameras off, I think, when we go from the breakout room back to the main room. So I hope everybody, I felt like our conversations were extremely beneficial and we got through a lot. We didn't, finish everything, no strategies, nailed down or anything, but I think that the conversation itself was really, really robust and everybody had a lot to contribute. So hopefully everybody else's groups were similar in productivity. So I thought that we could each, whoever I guess was taking notes maybe, or whoever was kind of the spokesperson or wants to be the spokesperson of their subgroup, could spend a few minutes sharing some of the things that your group discussed, or if you came up with an objective or strategies that you'd like to share with the group, that would be really great. And if somebody else from the affordable housing wants to share, that is great too. I do not have to be the spokesperson, and I would be more than happy to give that to someone else. Anybody volunteering to go first?
I can kick us off.
Okay, great.
I took notes, so I'm kind of the reporting back. This was the Affording Healthcare group. We were a small group, and really used the notes that you guys had developed, the ideas to kind of work off of that. We had some discussion around reducing the cost of healthcare, mostly through better access to home and community-based services, right? So options for people in the community. And the larger theme is if we can reduce the need for healthcare costs go down, right? So really thinking about preventative health-based measures and community access. Really focus some time talking about an objective around decreasing unnecessary hospitalizations and institutionalizations, and really thinking about what those data points might be to really understand those before we put measures in place that would be meaningful for the state. But having strategies associated with that are around having a comprehensive network of equitable and accessible HCBS, really thinking about that access in terms of like if things are ADA compliant and whether we're kind of regulating and looking at that. And developing community-based behavioral health long-term care options, thinking through some of the things that the state has already kind of begun thinking about and hasn't necessarily taken as much action on yet. And then we were really kind of talking through, kind of shifted one of the existing objectives to really begin thinking through how we're impacting social determinants of health or health status. And we're not sure what that measure might be, but to improve overall health. So we had one on here about sort of coordinating between community and clinical providers and really trying to maybe turn that into a strategy that really addresses this more preventative focus of health. And so some discussion around that. So one of the things that we noted is that there's a real need to kind of bring these ideas over to the other work group that's focused on health and wellness to see how they might relate to the objectives and strategies that are being developed there. And then in connection to that, really thinking through how to address overdose and suicide rate, which is much higher among older adults, and the opportunity to kind of use some of those metrics and really think about how we might be able to make an impact there, and kind of thinking through whether that is a strategy or an objective all on its own, and also where that might fit within this larger process. I think that's what we have to share. I don't know, Dan, anything that I missed?
No, I think you did a good job, Liz. Again, Liz has the notes, and so there's a lot of comments and things like that on the notes. That's going to take a little bit of working through, but I think you nailed the high notes. Again, it's just reducing, making healthcare more affordable by reducing hospitals by making sure that there's access to the services that more appropriate and the costly and less costly home and community-based services, reducing hospitalization, improving insurance coverage, making sure that people can access it through their insurance, through parity Medicare, things like that. And, again, making it unnecessary overall by increasing, overall health and wellness by addressing social determinants of health. And so, again, Liz has the notes. I think they look better in writing than they do with us saying it. But I think you nailed it. Thanks, Liz.
Thank you. That was really great. Who would like to go next?
We can go next, I think, with long-term supportive services, if that's okay. I took the notes, obviously, for our group as well. So please, anybody who is in that meeting, don't hesitate to chime in.
If you read it, Mark, I'll describe it. He was the note taker. So if you read it, I'll describe it.
No worries. So we started a conversation quickly by talking about and starting to draft just reducing the wait list, right? So trying to figure out how to reduce the wait list, and it quickly came to a discussion about expanding access to reduce the wait list. So it was a kind of a pivot there, but we came down with expand recipients receiving services through LTSS by increasing utilization and we threw a number out there, percentage out there, by 60% of older adults enrolled in subsidized LTSS programs by the year, and we're still kind of thinking about by what timeline. And then we came up with, and then we started kind of brainstorming. Go ahead, I'm sorry.
That one. Well, so I think, the good news is the group kind of came up with their objective. I think it's a solid objective, but we did recognize we got to do a little research to kind of come up with the measure. We got to kind of know how much are enrollees now or recipients now, across a certain department. So Carrie's going to take care of all of that and come back and report. No, I'm just kidding. She was definitely our go-to, but I think it was smart to say that the objective is there. Let's make sure that the measurable part is, let's do a little research on exactly how many are in, and do we need to look statewide? Do we need to define this by jurisdiction? And then, this objective may be a 1 and a 2 and a 3 step. It may be 20% by 26. It may be 50% by whatever. So, but until we know what more of the current roles are across the whole state, we do it. So, we did talk about maybe doing some homework behind the scenes between now and then, and our next meeting that'll give us maybe be able to define that. But I think the objective everyone agreed on was very solid, which then led to the discussion of the strategies. So, the subcommittee, we're ready.
Yeah, I agree. And I think like Liz said, I think we're just trying to get an idea of what the current utilization rate is before we start putting percentages on increases. And some of the strategies that are already kind of put out there have been reassessing income thresholds, the availability of caregivers and providing caregivers, local, regional individuals to navigate and process applications, to simplify the intake assessment and eligibility of the application, to reduce admin burden, and awareness of awareness in general of services. And Leslie brought up a really good point about just having those awareness in a collaborative way, collaborative resources, a one-stop shop, if you will, through the map to make sure that those services are easily accessible.
Right, which I think Ian was also saying too, if we're looking to expand the outreach, things like MAP and 211, where the information and referrals are so important, and especially as a single door in some ways, to really get the word out there more that we're here to help.
Great, thank you. I see Dan has his hand up. Dan, do you want to go real quick before we jump into the next work group?
Yeah, thanks. I just wanted to kind of say that we had the same kind of thoughts on our stuff about the you know the measurements and things like that and the percentages. We feel the same way that we need a kind of a baseline first. You know, we need to understand where we're at now instead of just kind of pulling numbers out of the air. You know, we need to kind of make sure that we know where we're at so that we can kind of defend, you know, the numbers that we're putting out there in terms of decreasing or increasing and things like that. So I just want to say that our group was in the same boat.
Perfect, thanks. Who would like to go next? So we, I think it's just housing and financial security that we're. To share the notes from the housing group, or do you want me to go over? You want me to share? Okay, you're on mute, by the way. So we also kind of noodled through those 3 objectives that the group had, that we had shared out with the groups. And we did do some wordsmithing and a lot of chatting about, you know, different priorities and how do we make sure that that it's not just affordable housing, like a affordable housing community built from the ground up, that it's, you know, about preserving what we have existing and maybe developing new. Maybe it's about keeping people in their homes and, you know, how do we define affordable housing, right? So with all of that, we actually created a rough objective. And so again, we don't have necessarily the percentages or the timeline yet, but the direction that we want to go in, and that's very important. So by whatever year, increase state investment in an age-friendly variety of housing options that are affordable, sustainable, and accessible, including preservation, development, and adaptation by, you know, X number, so that older adults can access aging and community initiatives. And by implementing, and this one we're kind of on the fence about, by implementing new programs to expand support of existing programs over the next number of years in order to improve housing stability and reducing involuntary displacements for reducing involuntary displacements. And one of the things that we are trying to figure out is in terms of metrics, so that involuntary displacements, how can we get be more proactive and get it before it comes to that involuntary displacement, right? And so what would be the metric around that? So I think anybody else have any? I think that pretty much covers. Great. Who is going to share for the financial stability?
So I took notes for the financial security group, but feel free, folks, to jump in for the folks who were present with us today. So a general problem or objective statement is improving financial security. So just for context, we couldn't quite figure out exactly, like, all of these objectives seem super and equally as important. So figuring out a way to try and combine all of those and understand that they all feed into each other was, I think, a consensus among the group. So improving financial security by increasing participation in retirement savings programs by X% over the next 15 years, promoting financial literacy, and increasing the average salary of workers across all age groups by creating a continuum of financial literacy education to learn and last through the lifespan. That will address the key financial literacy principles at various age stages and adequately prepare Marylanders to live long lives. So quite a mouthful, but they're basically 3 objectives kind of condensed into one, seeing that we hope that it'll be like, what is I'm forgetting the saying, but essentially we'll be able to get a perfect strike by just focusing on education and education across the continuum and continuing education across the continuum, starting from Early adulthood in high school will help to set Marylanders up for success. Some of the strategies that were discussed was spreading awareness about existing programs like the Maryland Saves program, which is, I believe, statutorily and regulatorily created to assist folks who might not otherwise have access to a retirement savings plan through their employer to get it through the state. Strategy number 2 was promoting education for the various educational groups. So an example of the educational groups and the various pinpointed education that would go towards those folks as they're aging along the continuum is, 15 to 25, 25 to 35, 45 to 65, 65 to 85, and 85 to 105 plus. And strategy number 3, creating employer-specific educational opportunities on ageism and aging workers as a protected class. Strategy number 4, employing CPAs that provide pro bono services for education across the continuum, and thereby incentivizing CPAs to grow their own client base. So one of our group members brought up that there are CPAs that provide pro bono services, and they're incentivized already to provide those services so that they can grow their client base. So using pre-existing programs such as those to help with educational efforts. So folks, jump in if I missed anything, but those are some of the notes that I captured.
Yeah, what we were trying to say was in the continuum is to start in high school and have a financial education that starts that you can't leave high school until you've taken this course, like a course on anything that has to do with finances. So we're starting with a basis with someone and then re-educating them again when in the other age groups we talk about up to 40 and then 60 and then whatever, because there's different things that are important in life at those different stages. And perhaps these programs could be offered at the local college, Maryland colleges, free at those different stages we're talking about to do that. But if we don't start with a basis to get us people to grow, knowing what they're doing and what's important with saving or what their checking account is what, credit cards and all that, we're failing our children as they grow. So that's my 2 cents.
I am so impressed with the progress that everybody made. I feel like I even got to strategies and yes, there is a little bit of tweaking, wordsmithing, and further researching. But wow, this has been a huge task, and we're only into our 3rd meeting, and here we are with some really solid direction, if not, almost finalized objectives. So I'm very impressed, and kudos to everybody. I guess, does anybody else have anything before we start wrapping up and talking about next steps that they want to add before? Good. Okay. Well, our next meeting is on the Monday, the 21st, I believe. And so hopefully on that day, we'll really kind of get into the meat of the strategies. It sounds like some folks did already start working on those strategies. But if you, as your homework, if you review that work group recommendations worksheet and kind of see what the format of the strategies is going to be, it has a short-term, midterm, long-term, and then it talks a little bit about some questions to for discussion, and so write some narratives around. So if you just want to kind of review that and be familiar with it when we meet on the 21st, and then of course, Izzy and I will go through all of the stuff that was talked about today and see if we can pull together any additional resources for folks to make sure that we're making the most of our time together in 2 weeks. I see Carl has his hand up. Carl? Carl, you're on mute.
I wanted to thank you, Tiffany, for sharing the notes from the previous meeting. I think that was a really good thing. Also in our group, we found that there's a lot of things going on in other groups that we weren't really familiar with. and a couple of the members told us that we were sort of touching on other people's path. So I think the notes are helpful. And one other thing, if we could also share the next meeting links in the agenda, that would really be helpful too. But all in all, it's great to see all the faces and get to know all the different people from all over Maryland. You know, it's just exciting, and I'm glad I was asked to be a part of it. Thank
No,
you.
that's really great. That's really great to hear. And I would love to end on that high note, but I didn't know if anybody else has anything else. Izzy, you have anything?
Yeah, no, I just reinforce what you're saying. You know, we've made huge progress today. Tiffany and I and staff are going to take what we've done today, right, massage it, wordsmith it around, and get it back out to you in advance of the next meeting. The idea at the next meeting being, you know, are we good with these? And then jumping into identifying the key strategies that we want to, that will be supporting those draft objectives. And ideally, we'll have the information in front of you in advance so that you're best prepared to finish the job at the next meeting. You know, of course, if we need more time, we can take more time, but the idea is if we can do this within the, confines of the next meeting, that would be perfect. But we have the flexibility if we need it.
And
I
Eddie,
really
you're in the
appreciate
chat. Thanks for sending the email attachments because that was easier to access. So yes,
We're going
definitely.
to do it that way going forward. Yes. Thank you.
All right, everybody. Well, I hope you have a wonderful, wonderful weekend. And we will catch up in 2 weeks.
Thank
All
you
right,
for
take
all
care,
your,
everyone.
thank you guys. Thank you.
Bye.